is offering effective lifestyle advice in the clinic setting. And addressing childhood obesity in the clinical setting is a huge opportunity, but also a big challenge given time restraints. I'd like to welcome our panelists who all work with patients on a daily basis and have diverse perspectives on what role clinicians can play in effective advice for children and families. I'd like to welcome Dr. Julia Getzelman, the founder of Getzwell Pediatrics, an integrative pediatric office in Noe Valley in Cow Hollow, Dr. Shadmar Basti, lecturer at Stanford University School of Medicine and founding board member of the Stanford Food Summit. He's also an associate clinical professor at University of Arizona School of Medicine, and they're the head of their Public Health and Prevention Center. And Dr. Elizabeth Shepard, who sees patients at Stanford's Pediatric Way Clinic, is a clinical educator at Stanford School of Medicine, working with pediatric residents and students. So we're going to start with a general question for the whole panel, and that is, should you always mention obesity at an office visit? And if so, how do you bring up the subject of overweight and obesity with families in the office?
Sure, I can start with that one. Yes, I think that you should bring it up, at least in showing families a growth chart and how the child is progressing. I think as pediatricians and other healthcare providers, we have a unique opportunity to see children at multiple times throughout childhood, specifically to talk about their health. And so their weight and other health issues are part of the whole picture. So I don't try to dwell on this specifically, but I would look at a family's or a child's growth chart, look at their height, their weight, and look at general trends. I don't always bring up numbers. I think we're at the point now where sometimes that's counterproductive. But at least looking at trends, finding out how that fits into the whole picture of the child's environment. And if I do see a child gaining weight rapidly, at least pointing this out and saying, what do you think is going on here, and do you have any concern about this? So trying to size up whether the family has a concern, either the patient or the parents.
I would just say that there isn't always a one-size-fits-all in terms of introducing the topic. It can be very sensitive. So definitely, generally, I think it's really important, as you mentioned, to use it as an opportunity, as kind of a jumping off point to find out, are they consuming calories in the form of juice, soda, sort of empty calories. But I think it's a sensitive topic, so it needs to obviously be handled with sensitivity and in the context of the relationship that you have with the family, hopefully.
I think it's challenging to focus, on obesity, or as a particular thing in terms of bringing it up. I tend to try to focus, as it was mentioned, in terms of pediatric, because I'm a family medicine physician, but with my pediatric patients, I do like to look at the growth curve. I like to look at trends, but instead of saying, let's talk about obesity or let's talk about overweight, I like to talk about optimal health. And then when we talk about the dynamics of a balanced life, in terms of how active is the child, and then getting a sense of their diet and things like that, we get a better picture of this, and then I try to focus the parents to look at that as having a balance for their child in all the different pieces. And then the side effects, as I put it, the positive side effects are the weight's going to be optimized, if there's a cholesterol issue, if there's a blood pressure issue, if there's an attention issue or grade issue in school or behavioral issue. All of these things are positive side effects of focusing on that healthy, balanced lifestyle.
Great. And Dr. Shepard, how do you try and fit lifestyle counseling into very short clinic visits?
Yes, that is a challenge, and I should mention that I work in a primary care community health clinic as well as in a specialty clinic, so I see both sides of that. And I've been in situations where I have 10 or 15 minutes per patient to really address their entire health for a year, and that's quite difficult. So really trying to get an overview of the entire entire environment for the child. What is their life like? Who do they live with? Where do they spend their days, whether it's in daycare or with a family or with a grandparent or at school? What are their activities? And you can usually do that pretty quickly within about 3 to 4 minutes, and you can get an overview of the entire life. And look at some key dietary components of that. Are they eating 3 meals, including do they eat breakfast before school? What are they drinking? Who's buying the food for the family? So with some very quick questions, you can kind of size up what's happening and then work with the family to try to come up with some interventions if you think those are indicated.
And one follow-up question for Dr. Shepard is, how do you work with parents who don't see their child's weight as a problem?
Yes, and that does happen, not infrequently. And I don't necessarily say that it is a problem if they don't see it that way. I really kind of look in terms of overall health and risk going forward. There are some families for young children in particular that might look at the weight, if you mentioned on the growth chart that the weight is starting to go up, and say, well, I'm really not worried. This is only my child, and they're only 3 or 4, and they're going to grow out of it. And I say, well, we see now that children don't always grow out of it, but let's just keep an eye on it over time, and we'll have you come back maybe in 6 months. I kind of do some negotiation if they're not ready to go forward. Or I might even just say, okay, let's see you back next year for a physical and see how things are going at that point. The only time when I might really try to encourage more quick follow-up would be if the child is indeed having some health problems that I think are related to the weight. In particular, sleep apnea can be a risk factor, even for young children, as young as like a year to 18 months of age.
Dr. Getzelman, what advice have you found to be most helpful for parents in your practice around this issue?
Well, I would venture to say in my practice that probably less than 1% of the kids are overweight or obese. So that's a pretty unique situation given what we know about national averages and so forth and trends. So what about my practice is different? We practice slow medicine. We have a lot of time with patients, with families. We get to know them. When a mom is pregnant, we begin a discussion about what she's eating and how the flavors that she takes in may influence her baby's future taste preferences even over a lifetime. We talk about why a vaginal birth has advantages for many reasons, not the least of which is obesity risk. We know that babies who are born by C-section are at increased risk for obesity. We talk about the importance of breastfeeding, and we go to great lengths in the practice to support families around breastfeeding. We have close relationships with lactation consultants in the community, and we spend lots of time, if it's necessary, in the office getting that baby latched on. We also have a sort of informal breast milk donation program going on in the practice whereby if a mom has excess breast milk, she drops it off, and we might share it with another mom who can't, make milk initially that's satisfactory for her baby in the first days of life in particular. So we also really take the prescription of antibiotics very seriously. And a lot of that ties in with what Dr. Miller spoke about in her talk. So we know that frank antibiotic use, C-sections, and breastfeeding are all related to the human microbiome. And we want to promote as healthy a microbiome as possible, which translates into a different metabolism and then a healthy weight. When we begin to introduce solid foods to babies, or teach families how to introduce solid foods in the practice, we've been staunchly anti-rice cereal and talk about the fact that a bland diet for a baby is really sort of something that came out of not good research but cultural tradition from the 50s maybe. And we want parents to introduce a really colorful diet, flavor, vegetables first, sweet things, even fruits kind of mixed in with the savory at first. And we promote a family meal. We use it as an opportunity to encourage parents who maybe aren't eating as well as they know they should to begin to kind of cultivate a culture around eating. And we explain that how they feed their babies and what they feed their babies is really a statement about their family's culture around food. And so we just begin these various conversations that hopefully are part of why we're seeing a very low rate of obesity in the practice.
Great, thank you. And we're going to talk more about C-sections and breastfeeding at the pre and postnatal health panel this afternoon, if you're interested. So Dr. Marbasti, how does increasing mindfulness around eating help with lifestyle changes?
I think mindfulness is very important in many ways. I think one of the biggest things is, as I was talking about before, I try to focus on health and wellness and balance in life. And part of mindfulness is having an awareness of where you are, what you're doing, and what is coming in to you, both in terms of senses around you, as well as the food that you take in, the people that you take in, the media sources and things that you expose yourself to. And then that in turn gets processed and then comes out in some way, shape, or form. And part of that process is what can lead to disease and what can lead to things like obesity and other medical conditions. And then also that same process, if balanced and mindfulness is actually applied, can lead to more optimal health. So I think part of what's really important is to really take a big picture approach. And I think in a pediatric approach, and me being a family medicine physician, oftentimes I'm the physician not only for the children but also for the parents. And so I do like to take a very family-focused approach in terms of food and eating. And I do talk about how, I think one of the biggest challenges I think with dealing with children and also with parents is actually connecting with the parents and reassuring the parents. A lot of that early time, especially for the first time parents, is really a lot of hand holding and a lot of kind of saying, hey look, we all make mistakes, there's things, and we all know that things happen, and you're doing your best, and the fact that you're here already says that you're in the top 5% of the best parents, and you're trying to do the best you can. So let's just give yourself a pat on the back. And then second of all, let's just say, guess what, you're now a role model. And as a role model, everything that you do, your children are going to copy. And so you have an opportunity, if you had a to-do list, if you had a list of things for New Year's resolutions that you wanted to do, now's an opportunity for you to try to do that, and we can work together so that you can do it as a family. And so I think developing that approach and being mindful of what's being done, both as the individual members of the family and the whole family, and bringing that sense of community at the family level is very important. And that translates into a lot of things. So I try not to get hung up in the details. When the facts come up, we talk about them. Okay, here's the raw numbers. But I really want folks to get a big picture sense of things. So when they have that big picture sense, then they're able to be motivated, right, to do it, and not just say, wow, okay, I have to make sure to take this thing. And we try to dispel myths, like the micronutrient of the week, whatever is the most famous nutrient that everyone's talking about. Everybody needs this now. As the previous talk, was saying, really it's about biodiversity. It's about a combination of things. There's no magic bullet. And unfortunately, that's the challenge of the society, which keeps us from having the mindfulness and the balance to be able to optimize health and results in things like obesity.
Great, thank you. And Dr. Getzelman, how do you help families sort through all the different media messages around food and nutrition?
I think Michael Pollan said, eat food, mostly plants and not too much. So I think that I totally agree with what you've said, and trying to keep the message really simple instead of focusing on the vitamin or the nutrient of the week. We live in a world where there's a lot of reductionism, but looking at the big picture and considering the broad strokes, I think is really important, especially when you're a parent and you're worried, and as you said, many first-time parents are. So just sort of talking about eating whole foods, a whole foods diet, and what that looks like, and we talk about organic food for the reasons that Dr. Miller described. Eat a rainbow. If you're reading a label and you can't pronounce an ingredient, it's probably not good for you. Minimize liquid calories. And one of my pet peeves is those squeezy packets that parents, unfortunately, use a lot because they're convenient, but they're just like any baby food, they're hyper strained, and when you look at the label, there's quite a bit of sugar in them. So those are just some of the ways that we try to intervene, but keep the messages as simple as possible.
And Dr. Marvasti, how do you counsel families in the clinic about avoiding those highly processed foods and incorporating more whole foods?
Well, I think first it's about education, and I think as you just mentioned, is the idea of keeping it simple is really important. I think that a lot of folks in this room and some of the other meetings that folks in this room probably go to, we're hearing a lot of the same things, and then we start really delving into some of the minutia, like, okay, well, which strains in the microbiome are the critical ones, and what level of diversity is it, and what chromosomes are involved? Those are neat, cool questions, but we really need to bring it down to really simple stuff, and we can't presuppose that everybody actually knows all the stuff that we think everybody knows. So I think that's really important. In writing, there's a rule that I think about that applies to the practice of medicine. In writing, you're supposed to kind of say, first you're supposed to introduce, I'm going to talk to you today about obesity, right? And then you're going to say, okay, the first step is I'm going to talk about 1, 2, and 3 in obesity, and then I'm going to come back and tell you about number 4, and I'm going to re-summarize it. And then you say it again. So it's about repetition. And you keep it very simple, and I feel like that applies in these settings too. So very simple messages like the message of Michael Pollan. We've all heard about the messages of, if your great-grandmother couldn't recognize, a label. I always say if you can't even pronounce it or you don't even know what it is, that's probably not really food. It's actually a food-like substance that's masquerading as food. And so I really like to kind of draw attention to that. So really eating real food and making a difference. And then really we have to get into a discussion about it. So I think part of it is I don't want to presume where they're coming from. I want to get a sense of where they're coming from. And then I want to be able to meet them where they are and then just keep it simple. And part of the beauty of a primary care relationship is you have a relationship over time. So you're not going to be able to cram it all in one visit or one session. Maybe the first time you're there, you're just developing a relationship and just developing that trust and that sense of understanding, and that's enough. You don't need to try to put it all in. You don't need to, wear your authoritative hat, But I think statements by physicians make a big deal. And if I may draw a parallel between the tobacco industry and big food, which I think is going to be coming more and more to the fore. There's a good deal of research in the literature on tobacco cessation that talks about how a physician telling a patient that I believe, like making a statement like this, that I believe that the single number one most best thing that you can do for your health is to quit smoking. And I highly recommend it. I think making a similar type of endorsement about dietary changes or avoiding processed foods or avoiding frozen foods or fast foods or minimizing it, that kind of statement I think still carries a lot of weight. And I think people who are in the healthcare field who have that kind of presumed authority and that sacred trust really with the patient, people really should exercise it in that way and try to practice what they preach.
Great. And Dr. Shepard, when should you refer a child to a weight loss program or specialty clinic?
Yes, I do have the perspective as well of being a specialist. I'd like to say first, I think Chad and Julie have made excellent comments about how to really supervise the health of children and provide them with the best opportunities for good health throughout early childhood, with method of birth, breastfeeding, starting solids, eating whole foods. I think those things are all vitally important. There does come a point sometimes when children are just gaining weight exponentially. That's what I would call it. If you look at their weight curve, it's just shooting straight up, and they're developing some health issues related to their weight. You might see acanthosis nigricans on the neck, or they have sleep apnea, or you check their liver enzymes and they have a fatty liver. I think if they're really showing exponential weight gain, there might come a point where you should refer them to a specialist. You might start with a nutritionist, and then if you feel that you would like to have a physician involvement as well, there's several multidisciplinary clinics around the Bay Area and probably in other places that you might live. This would be what's called by the American Academy of Pediatrics the third stage of weight treatment, which is comprehensive multidisciplinary involvement. It might involve a counselor as well, a psychologist or social worker. And then you get to stage 4, which is really more intensive treatment. And this would be probably someone who's a teenager who has extreme obesity. They might weigh more than 100 pounds above their accepted weight for height, and might have developed a number of health issues. And I see these types of patients every week in our weight clinic at Stanford, and some of them want to consider bariatric surgery. Certainly, we don't want the whole world to have surgery. I heard someone say that yesterday. It's not the best public health approach for every patient to end up having surgery. There are a few, though, that get to the point where the obesity is such a huge impact in their life and their health. Surgery is very life-saving and helpful. In some cases, it's necessary. For example, patients that are pre-transplant for a heart transplant, they have to lose down to a body mass index of 30 before they'll be put on the transplant list. So I've seen a few of those type of patients. So I think you can start with some of the intensive weight management, even in an office setting, seeing a family on a frequent basis, for example, once a week or once a month. But I find in the primary care setting, if you're trying to do weight loss in this way, it gets rather tedious for some families and they don't want to keep coming back to see their doctor. And that's when I think everybody else in this room that does other types of programs is very important. And we need to be able to link patients to those resources out in the community where they can get more teaching about vegetables and food and resources and activity. But once they reach that point where their health is really just getting worse and worse, I think it is time to make a referral. And then we'll see what treatment is indicated from there. Not drugs, but sometimes surgery.
And following up on that, a question for everyone is, what is the most important role clinical visits play in childhood obesity prevention? And what type of education or interaction do you advise patients seek after an appointment for continued support?
Well, again, I think that the relationship sort of forms the base of the pyramid, and you have to have established trust and know your family and your patient. I think you have to know what their resources are and what their capabilities are. But I think as in any realm of chronic illness, the relationship is foundational.
I would agree with that. I feel like although we're focusing here and discussing about childhood obesity, I think part of the stigma associated with it, I think it makes sense actually to kind of understand it in the context of, health and disease in general and balance. And I really feel that we need to get away from, disease specific. I think it was about 2 or 3 years ago, maybe a little sooner, more recent than that, but the WHO defined obesity as a disease. And I thought that was interesting because I think it says a lot about our paradigm in terms of how we approach health and disease and how we're trying to change things. So they thought that by calling it a disease, somehow you're going to be able to gain more attention and we're going to actually do something about it. But I find that to be a double-edged sword in clinical settings because sometimes I think a disease becomes a label and it becomes an excuse and it becomes an identity. And if you look at the literature in terms of sociology and social illness and the idea of disease and illness in terms of that, the sick role and kind of taking on that, and then when you combine that with a lot of the preponderant conventional wisdom that's thrown out there about genetics, I don't think most people other than people in this room are talking about things like epigenetics. So people kind of feel like, oh yes, well, obesity runs in my family now too, and I am also obese, and that's kind of terminal for me. So I really like to look away from that, and I like to focus again more on mindfulness, more on health, more on the big picture, and more on the malleability and kind of the Play-Doh-esque concept of children. Like the neuroplasticity, and there's so many different, it's like a tabula rasa. It's a clean slate, and it's an opportunity for the parent to also renew themselves in that process, and also be able to create the reality and a guide for them. And obviously they choose their own path, but being able to do it that way, I think that helps a lot more than kind of focusing on the specifics of that disease and defining someone that way. And then really highlighting things like epigenetics, talking about things like some of the studies that have done that show that actually dietary changes within a matter of weeks turn hundreds of genes on and off, pro-cancer genes off and, anti-cancer genes on, and things that people would just kind of look at you and say, what? Are you kidding me? And also the fact that your taste buds change over a matter of weeks. So I know that your kids, will never eat a vegetable because they didn't, eat it, but actually give them a few weeks. Put some, and tell them, I also like to bring in food whenever possible because I like to give food prescriptions. So, like for example, spinach is a big one, and I actually really, I think as a kid I was exposed to this and it actually worked really well. So just getting some fresh spinach, wilting it a little bit with some water, okay, and then adding, you know, good extra virgin olive oil, sea salt, and fresh lime. And that's a very tasty, savory dish. You know that you know even as a child, like you can play around with it, see what the palate of the child is, make it a fun thing, make it a tasty. It doesn't have to be boring. You know.
We've heard a lot about these food prescriptions, and do you actually write your prescription out on a notepad and hand it to the patient?
Yes, I type it up, and I actually type up handouts with specific food prescriptions. You know, with actually things to do, like for example, you know, 2 to 3 tablespoons of ground flaxseed mixed with water, and then have a fresh bowl of salad. And here's how you make the salad dressing. And I talk to them about some of my homemade salad dressings that I make. And I said, look how easy it is. It's quick. And nowadays with the triple wash, you know, organic lettuce, right? The greens. I mean, you don't even have to go sit there to the process of washing and drying your greens, right? So you can just take that and get your nice little vine ripened tomatoes, wash those up, cut them up, and then you're ready to go. You know, so yes, I like to give very explicit food instructions because again, as the previous talk was mentioning, you know, food is really medicine and it can be very powerful medicine and it can be very palatable too. And it doesn't have to be like take your medicine, you know, take your castor oil and you know, you're gonna not like it, right? As what did Mary Poppins say? A spoonful of sugar? Well, we don't want sugar, okay? Honey, yeah.
Great idea to bring up the concept of epigenetics. I think that's so important. It's really revolutionized how we've looked at weight in the last 7 to 10 years. I often say to a family, well, I think your child has a genetic predisposition to being overweight, but it's been brought out by the environment around you. Or at least I'll say that to the referring physician, not to the family. And the fact that you can alter the pathway, you're not destined to be at a certain weight or a certain health. There are lots of things you can do. And I'll often try to come up with quick wins. What's something just really fast, one thing that we can think of that might make a huge impact? And usually it's stopping sugar-sweetened beverages. And it's not just weight that it's affecting. There may be multiple aspects of health. And the child may also have asthma and constipation and allergies. And all of these things can be helped through changing lifestyle, changing food, changing activity, and interactions amongst family members.
And one last question for the whole panel is, for your patients who do struggle with weight, do you see a pattern in their relationship with food or how they make food choices?
I can quickly answer that and then I'll pass it on. Sometimes, yes, I think just eating quickly without really stopping to taste and realizing the good quality food, eating things that are rather bland, and really just not looking at food for pleasure and social interaction, but just as kind of numbing emotions in some ways.
I think there's a long history of looking at food just as calories, and so I think that the epigenetic piece, the fact that food speaks to your genes, and that you aren't kind of locked into this genetic fate, is really important if you have the opportunity to talk to patients like that. I mean, I think as physicians, we're just beginning to, you know, to really take this in and digest it. So it's very new and it's, I think, super exciting.
Absolutely, and I'm glad you mentioned calories because I'll just be very explicit. I'm not a supporter of the calorie hypothesis. I'm really about quality of the calorie and also the timing of the caloric intake throughout the day. And I think for challenging cases and pretty much for everyone, what I really find to be useful is the timing of the caloric intake. So really focusing on spreading out and kind of keeping the fuels of your metabolic fire burning throughout the day. So starting with a bigger breakfast, front loading with breakfast and lunch, and then having snacks, you know, the 5 meal concept. And then I say, you know, I even actually give a specific time, you know, like depending on work and school and whatever's going on, you know, like no food after 6 o'clock. You know, maybe you can have like a hot water with, you know, some good raw honey and a little bit of cinnamon, you know, as a snack, or little pieces of apples and just fresh whole fruit, not fruit juice, you know. That's basically it, and go to sleep, right? So really you're kind of burning throughout the day. And I think that idea is important, and I also think that, you know, again, how we're focusing on food and the relationship with food, as you asked about that. I think we all have a waxing and waning relationship with food that can be good or bad. I think the way we eat and how we eat and when we eat and what we eat is a real barometer of where we are in our lives. And so even everyone who's well-intentioned in this room who tries to keep up some kind of diet, quote unquote, or some kind of good, healthy approach, mindful approach to food, can sometimes have a really characteristically unhealthy approach and make some poor choices. And that's okay. And I think that's another part of it, is it's a dynamic, it's kind of a barometer of where you are, and that's the time to be mindful, is to say, hey, check in. We'll see, what was it? Where did that craving come from? Maybe even part of shifting your food is to actually minimize the amount, but still satisfy a little bit of that craving, and eventually you're gonna, when you start adding the good stuff rather than just start taking out things, like adding a fresh bowl of berries, adding that fresh salad every day, your body will know the difference, and you will react differently after you eat the other food that's highly processed. And you will feel tired, and you'll say, man, it was kind of tasty, but then afterwards it just didn't feel good, and versus I felt really light after the other food. And so that's another strategy too, is also adding the good stuff rather than just saying, no. Because what are we adding to, right? And I think, again, the talk that was previous is like, what have we missed? What have we lost? We have to look at kind of what we're adding here instead of just saying, making a long list of no-nos.
Great, thank you. So we have some time for questions.
So much for your shares. That was really informative. I guess my question is for Julia. I'm curious to know, can you speak a little bit more about the obesity differences between vaginal birth and C-section?
Well, I think what we know is that there's a correlation between C-section and greater risk of obesity. And I think the upstream reason is the colonization during the birth process. So we know that babies born by C-section are colonized with skin bacteria and some of the stuff that hangs out in hospitals rather than what is in a mother's birth canal. And it turns out that what's in mom's birth canal, typically is what helps to promote ultimately a healthy microbiome in that child. And in the first 3 years of life, that microbiome is getting set up maybe permanently for a lifetime. So perturbations like being born by C-section or getting antibiotics during that first 3 years, or not being breastfed, or even being breastfed mostly but getting some formula, it changes the mix. And it also turns out that probably even the baby born vaginally, even the baby breastfed for the first 2 years of life, even the baby not given antibiotics in the first 3 years of life doesn't have a gut like our kind of evolutionary history would want us to have. But we know that that gut is probably going to confer greater health benefits than the gut of a baby who's born by C-section, especially of parents who have a history of allergy, isn't breastfed and then gets antibiotics. I see some of those kids in my practice, and they come in with eosinophilic esophagitis for complex medical consultations, or severe allergy or eczema or other autoimmune issues.
Yeah, I have a question. Do you support parents who want to raise their kids vegan? And if so, how do you do that? Do you have anything that you recommend in terms of reading materials?
The question's for me.
Yes, that's pretty rare in the practice that I work in. It might be more common with the patients that y'all see, but I occasionally have parents that want their child to be vegetarian, which would of course include eggs and milk. Vegan, maybe just encountered a few. And I say, yes, it can be done, but we'll just keep a closer eye on growth and on vitamin status. As you probably know, pay more attention to B12 status. So yes, I think it can be done, but in infants, you have to worry a little bit more about really high fiber diets that might, interfere with getting adequate fat, so I would pay more attention in an infant in particular.
I think the importance with vegan or vegetarian particularly is make sure that you're a healthy vegan diet versus a unhealthy vegan or vegetarian diet. And by that I mean really processed versus unprocessed. And I think that, you know, if you're starting to just eat, you know, veggie meat and a lot of these processed things that are, you know, high in the soy isoflavones and things that actually can inhibit absorption of important minerals and vitamins, that's probably not a good choice. If that's what you're going to start doing, like, you know, the child is going to start, instead of getting, you know, maybe like a small portion of a good grass-fed meat, they'll get like this processed like tofurkey. You know, I would say, well, maybe you should just give them a little bit of that grass-fed meat instead of the tofurkey. You know, so I try to have that discussion to kind of gauge, you know, where they're, you know, what kind of approach, you know, they're taking. So I think if they're really doing a plant-based diet, like the again, that previous talk, looking at the Talahara people in Mexico, the genetic cousins to the Pima Indians, who are eating the tres semanas, the three sisters of the squash, the corn, and the beans. That's what I call like a healthy vegetarian. You know, like really good stuff that comes from the earth, and you're eating it and it's minimally processed. So I think that's really important, because I think people have this perception that, you know, meat is bad, and yeah, for the most part, it's bad for the environment. We should probably minimize its consumption. But what are we replacing it with? Is my question. And if we're replacing it with these really processed meat-like, or again, food-like substances, that people who really come from these cultures and communities where they actually eat mostly a plant-based diet, they don't have tofurkey. Again, no offense to tofurkey. I mean, I think it's a great transition for someone who's trying to transition from, you know, a meat-based diet to a vegetarian diet. I think those are great bridges to kind of bridge that gap for people who are transitioning, but eventually you should try to wean off of that and actually eat from the source that's unprocessed.
I don't know if I have much to add. We have had vegan parents in the practice, and we're committed to raising their kids vegan. I think mainly, you know, it is, you know, it's sort of like people who call themselves vegetarians, but they're really kind of crackertarians. So if you're a vegan eating a whole foods diet and getting enough plant-based fats, I think it's fine. I mean, you know, people are talking about paleo, and paleo being kind of the way that the ancient human being used to eat. Well, it turns out there's a huge amount of evolutionary history before, you know, paleo diets where, and probably most of human evolution, we were eating largely plant-based diets and some insects and once in a while a big game animal.
Hi, thank you for being here. I don't know if this is exactly on topic, but I think I have a sense that perhaps one of you or all of you can answer this. Sometimes I feel as a mom in a conference like this, I've heard several times things, you know, that you need to do during pregnancy, and I have this big mom guilt about that I didn't eat the right foods, and you know, all the things that you say that are best as far as vaginal birth and no antibiotic use and all those things. So what does a mom do that has, you know, now a 12-year-old son, such as myself, that may have had some of those factors happen? I mean, it feels like almost like, oh, it's too late, and that's the end of it. So what can you say that's hopeful and perhaps solution-oriented for people like that?
I can say something quickly just from the support point of view. We always start where people are, and yeah, I try not to promote feeling guilty for anything that's happened in the past, and let's just go forward from here. Yeah, and of course, you know, everybody has different things that happen in their life, and no one can be perfect, and so we're all just, you know, doing the best that we can. That's just a quick thought. Pass it on to you.
I think it's a great question, because we can kind of sit up here on our high horses and, you know, talk about optimal situations. I mean, you know, it turns out that there are probably twice as many C-sections in this country than need to happen for medical reasons, but half of those, you know, save lives. So again, I think, you know, you start from where you are, and you hopefully begin a conversation with your 12-year-old if he's open to it, and you model you know, the eating behaviors that you hope that he'll take on. And you know, sometimes it's difficult to, if you kind of have a history of what I call the white food standard American diet, it's hard to transition to color and whole foods. And you know, but you take baby steps. You know, maybe you get rid of the orange juice in the morning as a first step, and you talk about why you're doing that. You know, and he'll roll his eyes and whatever, but you just, you know, you can change the way genes are being transcribed in the body in very short periods of time. You can change the character and the profile of the microbiome by making changes in the diet. So you just, baby steps.
As long as you're alive, it's never too late. And I think it's about being mindful. So even if you ignore all the conventional knowledge and just try to do what's right and kind of moving in that direction, that intentionality, I think, goes a long way. And I think having that attitude and pace of mind, the mind-body connection is very powerful. So being able to put the mind-body connection at work, you know, and really being able to have an almost spiritual conviction to develop some kind of real connection with the principles of health and wellness and caretaking for yourself, and instilling that in your child, that will translate into all these details. The details will work themselves out.
Hi, I wanted to ask the panel about exercise and physical activity for weight control in children who are already overweight and obese. I've heard really conflicting things about, obviously it's healthy, it's a good thing for children to move more, but once you have a child that's already overweight and obese, what role does exercise play in really helping the child achieve a normal weight versus maybe having other benefits on health but not reducing the weight?
Yes, I think that diet is going to be the most important factor in terms of actually producing weight loss, for maintaining weight and maintaining a healthy life, and all aspects of health. Exercise is very important, but it probably has intangible benefits as well. You know, just getting outside of the house where you might sit down to eat is a factor, so it might in turn affect what you're eating. And so currently for kids, you know, recommendation would be at least 30 to 60 minutes per day, and usually for someone that's inactive and hasn't done much, I'd say just go outside for 5 minutes and just start with that. And often if you do that, you'll find you want to stay outside longer. So it does have a very important role to play, but in terms of actually losing weight, the diet is going to be the key component.
We have time for one more question.
Can you talk about the use of behavior modification or health coaches to help your patients implement the changes on a longer term basis rather than just the visits to your office?
I think there's some models in, you know, team-based care, team-based approach is very important. And obviously you have some approaches where there's more time that's spent and you're able to subsidize that. Maybe a direct care, maybe it's a concierge-like practice, maybe there's a membership. But in a lot of situations, the team-based approach is really going to be most helpful. So, for example, places like I think Kaiser Permanente does a fairly good job, depending on which region, with their health coaches, and they have kind of a warm handoff between the primary care provider and the health coach. And so they basically kind of talk about and introduce the idea of lifestyle modification. And you know, I really still believe that it's very important for the physician to have that motivational interviewing component to the dialogue, but then really you can make a warm handoff and say, okay, and here's, you know, so-and-so who works very closely with me, and they're going to talk more with you about some of the details, and then they're going to follow up with some emails, and then we'll check in like another month or so, and we'll kind of see where you're at. So I think those things can be very useful, again, depending on the practice situation, but I think it has to be a working relationship, and it has to be introduced by the provider, and they have to kind of get buy-in from the patient to this idea that this is an extension of me, kind of a team approach.
Yeah, I think as well it's very beneficial often to use other providers to help with coaching or behavioral support. And I still like to be involved, as Shad said, but I often refer to other providers or have somebody right there in my clinic. We have a group weight control program at Stanford where kids can interact with each other. Or having an individual coach, all of those things I think are extremely helpful if we work as a team together for the patient.
Great. Thank you all so much.